she specializes in, or she has a PI and a grant really focused on addressing rural adolescent e-cigarette use and vaping prevention. And so we're really happy to have her here today. Holly, I'm gonna let you take it away.
Thank you so much for the great introduction and for inviting me to participate in your group. I'm going to try to share my screen. Hopefully, I can do it gracefully. All right, here we go. So, we're going to talk, as Dr. Heatley mentioned, about, nope, that's the wrong. There we go. That's right.
Oh,
Is
we
the right mode?
still, oh, there we go. Success.
Okay, success. I'm going to talk about adolescent e-cigarette use, both kind of prevention and treatment, and I'm going to try to do it in 20 minutes. So it's going to be a little bit of a whirlwind tour. So I'm going to go quickly, but I also do prefer for it to be interactive. So please feel free to interrupt. And because I'm going quickly and might not be paying 100% to the chat, just feel free to unmute and say like, hey, Holly, I have a question. So briefly, the learning objectives to talk a bit about the epidemiology. I'm not going to spend a ton of time on that because I suspect you all already know a lot of that. I'm going to talk about one particular framework for screening and brief intervention around adolescent e-cigarette use, and then review strategies for treatment options for adolescents who want to quit or cut down. I'm going to spend the most time on that aspect. So just so we're all on the same page about what we're talking about, electronic cigarettes, e-cigarettes are battery-powered devices. They heat a solution of liquid nicotine that's often flavored. There's also other chemicals. This creates an aerosol that users then inhale into their lungs. This use of these e-cigarettes is often called vaping. So you'll hear me kind of use those terms interchangeably, like e-cigarette use and vaping. Trends that we've been seeing, you can see between like kind of the early 2018, 2019, there was a huge increase in e-cigarette use, where about 20% of youth, so middle and high schoolers, were using e-cigarettes. There's a gap in some of the data there because of COVID, and the 2020 survey did not go out. But then in the last couple of years, we have seen a decrease in the frequency of use. The thing that is most concerning, I think, about current users is that they are using them quite frequently. So while we have seen a decrease in the use, the teens that are using them, so among like the 6th to 12th grade set, those who use them very frequently. So you can see here that 26% use them every day and 38.4% use them on 20 out of 30 days. So quite frequent use. But what is encouraging about this data, I think, is that they are interested in quitting. And this is really where I think our role as health professionals comes in, is that the teens are interested in quitting. So almost 2/3 of the teens they surveyed had a past year quit attempt. So we can really capitalize on that. In terms of kind of part of the health background around this, there's a lot of myths around this that it's just harmless water vapor. That is certainly not true. In addition to the nicotine, e-cigarette aerosol can contain ultrafine toxic particles, heavy metals such as lead, tin, and nickel. The flavorants are some of the most concerning particles that people are inhaling. Diacetyl was the thing a couple years ago that caused that bronchiolitis obliterans that made the news. Popcorn lung, it was I think probably responsible for that huge decrease back in the late 2019 2020 range around the COVID era. But one of the things that I think is really scary from a public health perspective is that e-cigarette use can undermine social norms about tobacco and nicotine use in general. We made these huge strides around decreasing the use of cigarettes, and that there is concern that e-cigarette use is undermining that progress. We do know that young people in the US who have ever used e-cigarettes had a 7 times higher odds of using combustible cigarettes and an 8 times higher odds of currently using cigarettes 1 year later, compared with young people who had never used e-cigarettes. So it really does increase their risk of using other forms of nicotine, particularly combustible cigarettes. And then there's the concern about nicotine, which is the highly addictive chemical in all tobacco products. Disposable e-cigarettes have nearly tripled in nicotine strength, quintupled in e-liquid capacity, and then dropped in price by nearly 70% between 2017 and 2022. So we're talking about a huge increase in the sheer volume of nicotine and then also the access by because it's becoming so inexpensive. Nicotine is known to have potential to harm the developing brain of adolescents and young adults. It can lead to lower impulse control and mood disorders. It can disrupt attention and learning among youth and young adults, and it can increase the risk for future addiction to other substances. Um, when surveyed about why they vape, the teens often say, you know, a lot of this is good old-fashioned kind of peer pressure. A friend first used them, curiosity. But then around why they continue to vape, this is, you know, I think again where we as mental health and healthcare professionals come in. A lot of the reason they're continuing to use is because of underlying mental health issues. They feel anxious, stressed, or depressed, and then they want to get higher a buzz. And the reason to intervene with teenagers is because almost all adults who are addicted to nicotine started smoking or using other tobacco products in their teens, and nearly 9 out of 10 adult smokers started smoking by the age of 18, and almost 100% started by the age of 26. So the time to intervene is in adolescence. As part of our project, that Dr. Heatley mentioned, one of the things we have done is actually done focus groups in the rural regions to talk to teens about what they think would help. And we talked to teens and parents and some of the school staff. And one of the biggest things I would say that came away from that, I'm not going to spend a ton of time on this because it's kind of a whole other separate topic, but one of the biggest things was that the teens really felt like they wanted a supportive, non-judgmental environment. They were very worried about sort of the judgment, the stigma. They wanted privacy, and they really did not want parental involvement. The parents, they agreed that what was happening currently was around sort of punishment and disciplinary responses was not currently working, but they did want something that addressed addiction, the underlying addiction to the nicotine. They wanted consistent school responses with clear consequences, better communication. And of course, the parents wanted parental inclusion when appropriate, but they did recognize actually that not all homes were safe or that it wasn't always a supportive environment for teens to have their parents involved. Okay. So I'm going to sort of change gears here and specifically talk about how to address this in schools and other clinical settings. This is the framework that I was referencing at the beginning. It's called Ask, Counsel, and Treat. It's a framework developed by the American Academy of Pediatrics and the CDC to help pediatric clinicians address e-cigarette use. It's based on SBIRT, which is Screening, Brief Intervention, and Referral to Treatment. It's a model that was developed by SAMHSA, the Substance Abuse and Mental Health Services Administration, and has been used for years in sort of the adult mental health and substance use world. So ASK is the screening piece of this. The AAP recommends universal screening for tobacco use and other substances starting at age 11. And the reason for doing this universally, I'm sure this is obvious, but it reduces bias in the delivery of care. So it ensures that every child is asked without presumption of who is at risk and who isn't. It is important to explicitly inquire about vaping rather than solely asking either about e-cigarette or tobacco use, because teens may not perceive them as equivalent. They may not realize that e-cigarettes are vapes. They might not realize that if you're asking about tobacco use, you're asking about vapes. And schools can certainly integrate this screening as part of either school, like sport physicals or other pre-participation physicals. I believe that this is a thing that schools could do universally. There are validated screening tools that can be used. There's the BSTAT, it's a brief screener for alcohol, tobacco, and other drugs. The more commonly used one is called CRAFT. you have to use the 2.1 version, which has nicotine included. That actually the original craft does not include nicotine, which is, I think, sort of ironic. Um, the interesting thing is, research shows that adolescents report greater comfort and likelihood of honesty with self-administered questionnaires as opposed to face-to-face interviews. And I think we can all kind of imagine how this is true. So the important thing is to have the teens do the questionnaires on their own, either in electronic form or paper, and then go over the responses with them afterwards. Once a screening tool is positive, if you're asking more about their e-cigarette use, I just want to kind of put it out there that it's quite difficult to quantify e-cigarette use, much easier to measure combustible cigarettes because you're just counting how many cigarettes they smoke or how many packs per day, etc. There's no unified agreed upon measurement for e-cigarette use in public health. It's really challenging right now. Hopefully, eventually we'll get there. But the problem is there's so many different products, so many different types of liquid that people are putting in. So some advocate for total puffs, some advocate for measuring the total nicotine, some for frequency of use. So in some ways, it's kind of your best guess. The next part of the ACT framework is the counsel aspect. This is like the part of the brief intervention part if you're thinking about the SBIRT framework. Most mental health professionals can do basics tobacco nicotine cessation counseling. If it's something that you're really interested in, there is an accredited program from the Council for Tobacco Treatment Training Programs. I will share my slides with the team, and this is a live link. Whoops, sorry about that. And there are a lot of trainings that you can do that are completely online if this is something that you wanted to get additional training with. The important thing I think in the school setting with teens is to align with the developmental stage of adolescence. So this is when they're really developing their autonomy and independence. And so you want to have a treatment plan that's presented in a clear and personalized manner, but that really highlights their strengths and that empowers the teen themselves to make their own healthy choices and has it be about them and what their goals and hopes and dreams are, and not obviously about you lecturing them about the dangers of smoking. We all know that that isn't going to work. Some strategies. So one thing I recommend is to get permission to even talk about it. So if we're starting with a screening tool, we get that it's a positive screen, we have some idea of how much they're vaping. Before we launch into kind of a whole spiel about the dangers of it, etc., one thing would just be to ask, can we talk about this? Is this something you're even interested in having a conversation about? Approaching it just kind of, again, from the teen, letting the teen have control, having some autonomy about it. And then ask. Start with what does the teen know already? They might actually know quite a bit about the dangers of it already. It's not uncommon that schools are doing a lot. I mean, again, as you know, about kind of the basics around the health dangers, etc. When we talk with the teens, they said, we already know, we know it's dangerous. Like that isn't enough oftentimes. So what do they know about quitting? What might help? And then again, I think this is the most important piece with this adolescent brain development stage is to honor the autonomy, that this is up to you. Can I give you some information? How can I support you in whatever stage you are in your journey? Some factors that are important in terms of the having an effective brief intervention. When we were talking with the teens, that privacy piece came up again and again. So I think outlining the terms of confidentiality are very crucial. So one thing they really seemed to be worried about was like the mandated reporter aspect of talking to any kind of person at the school or health professional about this. In New York State, substance use disorder treatment is considered a topic that teens can receive treatment for confidentially. So I think it's important that from the get-go, the teens know that they can talk to you about this and that it's confidential. And so that they know you're not going to share this information with their parents unless, of course, there's a safety concern, et cetera, or a reason. And so letting them know when the limits of that confidentiality, but then facilitating conversations when appropriate with parents, family members, and caregivers. And the other thing that's important is that studies have shown a dose-dependent relationship between the number and intensity of counseling sessions and cessation rates. So in the school setting, this can look like brief, short interval follow-up sessions. So they do not need to be long sessions, short sessions frequently over time. And then this is my favorite topic, but thinking about the motivation, the reasons for their attempting to quit, supporting their autonomy around the reasons for quitting. So many adolescents cite long-term health consequences and like sports or school performance as motivators. So really latching onto that and exploring what is important to them. And then also exploring barriers to quitting, which is an opportunity for problem solving in the quit attempt. And then always thinking about how can we move from thinking about change to actually making the change? And then how can you help the teenagers get along that pathway? These are just techniques that can help, again, kind of moving a patient or teenager along that ambivalence on a scale of 0 to 10. How is important is it? How ready are you? And how confident are you that you can make this change? And essentially, as long as they say anything that's not a 0, you have something to work with. So I always ask all three of these questions. And then again, as long as they don't say 0 for all three of them, if they say 0 for all three of them, probably just wait a little while, have them come back and ask again. Because if they say 0 for all three of them, they're really not ready to quit. But if they give you at least a 1 on any of them, you've got something to work with and you can take that and run with that. Okay, and then lastly, I want to spend a little bit of time talking about what the recommended treatment options are. So, what works for vaping cessation? As you remember from the beginning, about 2/3 of the youth in the US who use tobacco products, including e-cigarettes, report wanting to quit and trying to quit. However, the evidence around how to prevent and limit youth vaping is quite limited, and there is a need for more robust studies. The best evidence that we have shows that in patients that have moderate to severe dependency, the best outcomes are likely from a combination of behavioral and pharmacotherapy. The best evidence that we have around behavioral interventions is for the This Is Quitting program. It's designed by the Truth Initiative, which you've probably heard of. They did a lot of commercials around combustible cigarettes. They created this program with input from teens, college students, and young adults who had attempted to or successfully quit vaping. It's a texting program, so those without a quit date receive messages for at least a month, and then program users who set a quit date receive messages for 1 week prior to the quit date, and then 2 months following the quit date. It was published last year, and as I mentioned about there not being a ton of evidence around this, it was quite literally the first published randomized clinical trial of a quit vaping program for teenagers. So there really is not much evidence around this. But as you can see, what was interesting in this program is that the teens that got the text message intervention had a 37.8% quit rate, which was like a point prevalence absence. I think they asked 30 days after. And then interestingly, the assessment only control, which is just people that they like checked in with, had a 28% quit rate. So just actually having some kind of person check on you, even if they weren't getting the actual text message, seemed to make a difference as well. This is just a little bit more about the This Is Quitting program. And here are some other resources. There's a lot of other online resources. I did want to mention we, as part of our program, have an app that is a bunch of video games that was developed by the team that I work with. It's called Break the Vape. So if you, it's available on the App Store for Apple, and actually it is now available. It wasn't before on the Android app store as well. So it's called Break the Vape. There's like 5 different little cute little video games, and essentially it's designed so that when you have a craving, it's designed to keep you busy for like 10 to 15 minutes, so like long enough so that the craving passes. So that it's not it's like more of a distraction kind of technique than anything else. But so please feel free to use that and hand that app out to or recommend that app if you have teens that are looking to quit as well. And then this is just a list of resources that's from the American Academy of Pediatrics. And then I'm just going to talk for 1 minute about nicotine replacement therapy here. nicotine replacement therapy is recommended by the American Academy of Pediatrics. It is off-label for youth, but it's recommended for youth who are moderately or severely dependent on nicotine. Um, and we might ask what defines moderate to severe use. Essentially, it's if you're having trouble stopping. So if you have craving, withdrawal, tolerance, increasing use over time, or any kind of consequences from nicotine use, and I would say that any teen that is having consequences in school from their use, like, would count as having moderate to severe um, nicotine use. This is also a scale that we developed that we didn't develop it, sorry. It's a Fagerstrom scale is a use for cigarette use for combustible cigarettes. We modified it for vaping. You can see this is really the main thing that we changed, which is how many times a day do you vape? Um, it's really hard to measure, as I mentioned, so we made it be 5-minute sessions. This is a not perfect measurement, but it's the best way we could think of to quantify, again, sort of in a standardized fashion. I don't think it necessarily means that you have to use this tool, but it's just one way to track over time. And then very, very briefly about nicotine replacement therapy, it's a medication that addresses nicotine withdrawal symptoms by providing a controlled amount of nicotine, and it helps reduce the urge to smoke or vape. It comes in gum, patch, lozenge, spray, or inhaler. The spray and inhaler aren't really available anymore, so essentially it's gum, patch, and lozenge available in the US. There's really not research on NRT in youth, but there's no evidence to suggest harm. You do need a prescription for youth under 18. It's considered safer than cigarettes, e-cigarettes, and other tobacco products because it delivers nicotine without the other toxic chemicals and carcinogens, and it has a very low potential for misuse because the nicotine is absorbed slowly. School-age patients definitely need a letter from the prescribing clinician to allow them to carry the gum or the lozenge with them if they're going to use it as needed. Alternatively, it can be kept in the nurse's office. I don't usually recommend this because I think it's a huge barrier to them actually using it. There might be some concerns from the school staff or the parents about the adolescents sharing the NRT. This did come up if the adolescents like had it with them. I think it's really unlikely because the gum and the lozenges are disgusting, but it's really low risk if it happens. And so in conclusion, this is kind of the summary from both like the focus groups that we did and also just the sort of summary of the research. We recommend for schools to build confidential, non-punitive help-seeking systems, to offer treatment referrals if possible, to shift the culture by creating vape-free zones and visual cues, and to emphasize belonging. We also think it's really important for adults to model the desired behavior. I didn't spend a ton of time on this, but it was something that came up in the teens focus groups that they saw the adults in their life vaping, and it was confusing at best. Um, we suggest emotion and identity-based messaging rather than risk-based because the kids know the risk and that does not seem to affect them. The students seem to respond more to emotion and stories. The parents seem to want more evidence and facts, and then to leverage pride and connectedness for school-based prevention campaigns. And then this is just a list of resources. Okay. So I know that was very